everyone, and welcome to Real Life Talks. I'm your host, Yvonne Heath, author of the book Love Your Life to Death, and founder of the I Just Showed Up movement. So I am so honored and excited to have my guest today, Dr. Naheed Dosani. Dr. Naheed is an incredible human. He is a palliative care physician, a health and human rights activist, public speaker, a TikToker, and founder of PEACH, which is Palliative Education and Care for the Homeless. Dr. Naheed and I first met on Zoom in February 2020 during the pandemic. We had a fireside chat with the lovely Laurel Gillespie talking about advanced care planning, Canadian Hospice Palliative Care Association, and we had a wonderful conversation with people across Canada. So Naheed, welcome. Thank you so much for being my guest today. How are you doing today?
I'm doing well, and thank you so much for that kind introduction. It's been just so great to meet you since that day over Zoom and to learn more about what you're doing. It's an honor to be here with you and all your viewers today.
Well, thank you. And, you know, it's my whole message, being a nurse, realizing we are a society that is very ill prepared for grief, death, and dying. I am being the change I want to see in the world, as you are. And my great message is, when we don't know what to do, we don't know what to say, we need to just show up. And you are the epitome of the beautiful person who is choosing to just show up and support our most vulnerable community members. And I would love to just go back. I mean, as if it wasn't enough being a palliative care physician, Naheed, you have gone above and beyond. And it makes me emotional just thinking of everything that you do. Geez, it usually takes me at least 10 minutes to feel choked up, but I'm already here. But I would love to go back to, I believe it was 2011 when Terry came into your life.
Yeah, I mean,
right?
That's basically when I started to realize we needed to do better around human rights and palliative care access. And can I tell the story? Or?
I would love to tell the story. And I first heard the story watching your TED Talk, which I would encourage everyone to watch. I took like 5 pages of notes and watched it 5 times.
Well, yeah. So I was a first-year resident trainee at the University of Toronto, working at a shelter for supporting men who are experiencing homelessness. When I was asked to see a gentleman on the first floor, he was writhing in pain. He was shaking. He was curled up into a ball. And as I began to examine his mouth, I could see that he had a tongue cancer that had spread through his head and neck. And tongue cancers and head and neck cancers can really, really hurt when they spread. The thing with him, his name was Terry, was that he actually was diagnosed a year before at a local cancer center. And due to his schizophrenia, his longstanding mental illness and substance use on the streets, he wasn't able to organize in his ability to go back for follow-up and treatment. So as time went on, he began to experience pain. So he did what any one of us would do. He went hospital to hospital, ER to ER, walk-in to walk-in clinic, seeking the kind of pain control that all of us should have access to. Unfortunately, perhaps due to stigma, Terry was denied access to pain medicines in healthcare when he really was justified for it. And so he found himself in our care on this day that you speak of. And I tried to build a rapport and trust and tried to connect with him. And he promised me he would start some pain medicines. And I went to bed that night thinking we're making progress, and got to work the next day really early and couldn't find him anywhere in the cafeteria, in his room. And one of his friends called from down the hall and said, "Hey, Doc, are you looking for Terry?" And I said, "Yes." And he said, "Oh, you didn't hear? Terry's body was found last night by a commuter on her way to work. He died last night. He had overdosed on a combination of alcohol and street drugs." And this was a very traumatic event for me. I needed to take some time away from my training. It showed me that we were not only letting people down in terms of their homelessness and poverty, but even when people were dying, they weren't getting access to palliative care, which is a human right. And so it was a real turning point and a life-changing event for me.
Your story is heart-wrenching and then heartwarming because, you know, when we have a tragedy, when we witness a tragedy, something horrific, we have 2 choices, right? We can pretend it didn't happen, we can move on with our lives, or we can take action and do something about it. And that is what you have chosen to do. And, you know, when we relieve suffering, it is an extraordinary gift to that person and to ourselves. right? Because when we ignore human suffering, I believe that moral, we cause ourselves a moral injury, and we've normalized a lot of the wrong things in our society, and this is one of them,
I
right?
think
And
I think that's a really great point, and we talk a lot in my world about the concept of double vulnerability. When doing this work, you're talking about people who are experiencing homelessness and poverty. We know that this population is 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, 4 times more likely to have cancer. They're very sick. Their life expectancies are half what people who have homes are. And then the other vulnerability, the vulnerability of dealing with a serious life-limiting disease and approaching end of life and approaching that situation in your life on the streets and in shelters. And so when you overlay, these are people who are falling through the cracks again and again and again. And I realized Terry was just one example of so many in our society. And I'm in Toronto, a world-class city when it comes to cancer care, palliative care and healthcare in general. And here was someone who was just a few blocks away from some of the world's greatest centers that do this work and wasn't getting access to that kind of care. We have to do better. And I knew we had to do better at that time.
We have to do better. And again, in normalizing where we can just step over people with our double espresso and somebody is lying face down in the street. And there's also hidden homelessness, and it is in every community. And I just want to say right here, right now, the elephant in the room, this is not the homeless people and us. At one point, they were babies, they were children, and things along the road of life happened to them. When I was 31 and became divorced and a single parent and I had no money, if I didn't have family to take me in, where would I go? I had a son who went down a very dangerous road of drugs and addiction, dealing with his own emotional pain. And if he didn't have a family, he would have been on the streets. So this isn't, we're all part of this community. And it is up every one of our responsibility to do something, to educate ourselves and to be a part of this change.
I think that's a really great point. And when you think about, if I was to survey, 10 people on Yonge Street today, I suspect 8 or 9 of them would have inappropriate stigma or thoughts about what it means to be homeless in Canada or experience homelessness. I hear this all the time. They did it to themselves. They're lazy. They use drugs. These things are actually not true. In fact, I've cared for many, many people experiencing homelessness in different settings, and I can say for certain, I've never met a person who wanted to be in the situation they were in because they wanted to be. People experience homelessness or get into that situation because of an unfortunate sequence of events, because of a weakening social safety net, because of weakening supports at federal, provincial, and regional and municipal levels around healthcare, around social assistance, around housing. These issues and causes are multifactorial, and we need to destigmatize what it means to be and experience homelessness. It could happen to any one of us. So many Canadians are 1 to 2 paychecks away from being on the streets or living in shelters.
Absolutely. And the same with mental health issues. And if without the proper care, any of us could spiral. And addictions. I will tell you right now, if I was in excruciating pain, and I've worked in the emergency rooms, they say, oh, there's so-and-so again. He's just or she's just a drug seeker. Well, why are they seeking those drugs? And if I was experiencing excruciating pain, yeah, I would do whatever I needed to do to relieve that. And so having these conversations is so critical. And when we don't know what to do and we don't know what to say, we often avoid thinking, I can't make a difference. And that's not true. We can all make a difference. And it starts with educating ourselves.
I think educating ourselves and also equipping ourselves with the understanding of what trauma-informed care can look like. I think we're talking more and more in healthcare about this, and I'm really grateful for that. The recognition that there are people in our communities, like people experiencing homelessness, people who live in poverty, people who are dealing with, racism or systemic racism, who have experienced trauma at the hands of healthcare, at the hands of institution, at the hands of government, and therefore seek to avoid it. And in the COVID-19 pandemic, we're seeing what trauma is doing. And when we talk about vaccine hesitancy, we're talking about people who have mistrust of the healthcare system. And what we're trying to do really rapidly in the middle of a pandemic is convert those feelings of mistrust to trustworthiness. And that's what trauma-informed care really centers around: compassion and building that trustworthiness. I think we talk a lot about trauma-informed care now. I think people aren't as equipped to know how to do it. And we're at that phase, I think, where we're trying to get people to learn how to do it. So absolutely, it's conversations like this that are the starting point.
Mm-hmm. Well, and I think when people see something, it's just so huge. It's just too overwhelming. And here's the thing, right? If we each took a step, and then the next step, and then the next step. And I mean, some of the things that you have, some of the programs, things that you are a part of, would you ever have envisioned and being a part of that or creating that? Like Peach, tell us about Peach, because I think that's just, it's extraordinary.
Thank you. So after Terry passed away, I took some time away and learned, a lot of the things that we're talking about here, Yvonne, about the fact that people experiencing homelessness are the sickest people in Canada, that life expectancies are half of what they would be for those who are housed, that there is deep-seated stigma and I think sometimes hatred for people who experience homelessness on the streets, which has led to poor health outcomes and less access to healthcare. So I teamed up with colleagues at the Inner City Health Associates in Toronto and created in 2014, and during my palliative medicine residency training program, created a new program called the PEACH program, Palliative Education and Care for the Homeless. We're a mobile, street and shelter-based supportive and palliative care program that aims to provide healthcare and palliative care supports to anyone wherever they're at, whenever they need it, on the street, in a shelter, under a bridge, so no person falls through the cracks. It started, with myself and a street nurse driving around out of my Honda Civic, and has now turned into like a 24/7 interprofessional care program that features health navigators, nursing coordinators, home care teams, home care coordinators, palliative care physicians, and psychiatrists, caring for between 110 to 120 clients at any given time in the city of Toronto. And we've really grown during the pandemic due to the unfortunate events of the pandemic and what that's meant for people living life on the streets, to deliver palliative care through a trauma-informed approach, through a harm reduction approach, so that everyone has access to the basics of palliative care, which is a human right.
I just love that so much. I want to be a part of this. Like, it's just, when you think of that, and when you think of meeting people where they are, where they want to live and where they prefer to die. In my 27 years of nursing, I have been at the bedside of more people than I can count that died in the hospital, that did not want to die in the hospital, people who were misplaced in society dying in Emerge. That is just the most horrifying end of life. And when people think, oh my goodness, someone dying under a bridge, think, how amazing if that's what they choose with their friends or the people that they care about in their familiar surroundings, as opposed to blood pressure machines. And yes, amazing. Amazing that you can offer that.
Exactly. We know that nearly 90% of Canadians, when surveyed, when asked about their end-of-life journey, want to be at home. They want to die at home, have their end-of-life journeys at home. What we know is that for people experiencing homelessness, our experience is that about 90% of people want to die at home. Just what we've been able to derive as home care, the type of healthcare system we've designed, is structurally incongruent with the ability to deliver home palliative care for people experiencing homelessness. I mean, I know it sounds like semantics, but we literally called it home care. What do you think that means? That means we structurally excluded people experiencing homelessness. And there are examples of explicit and implicit barriers to accessing care in our healthcare system all over. That's just a really obvious one. And so what the PEACH program aims to do is to try to work with home and community care and community healthcare to deliver palliative care in non-traditional environments, and do it in a way that meets people where they're at. Meeting people where they're at can mean anything from learning how to pronounce someone's name, to seeking their preferred pronoun, to supporting them, sitting at eye level when you're speaking with them, if they're seated, for example, or trying to get them to connect with healthcare in ways that work for them because of previous traumas in healthcare. And what we know is that people do better, they feel better, and they're more likely to trust healthcare if we approach it that way.
It sounds to me like you're talking about compassion, respect, and kindness, right? I mean, it isn't rocket science. It isn't rocket. You're talking about basic human rights of respect and kindness.
Yeah, it's a fair point. We have a medical education program where medical students and resident doctors come through and train with us, and the message resonates with them. But many of them ask towards the end of their rotation, "Isn't this just the way that all of healthcare should be?" And I say, you know what, you're absolutely right, and we're counting on you to go graduate and make the rest of healthcare that way. It's a sad state of affairs that we have to even have conversations about things that aren't rocket science, Yvonne. It shouldn't be rocket science to provide compassionate care for people, but we've come so far, in healthcare and the development of our healthcare institutions that I think we've might have forgotten about the care. Sometimes we got to put the care back in healthcare, and I think compassion has to be at the center of that.
150%. And I just want to go back to something you mentioned, and I want to make sure people understand the concept of harm reduction. That is remember the campaigns with drugs. Don't do it. Like, right? Don't do drugs. Say no to drugs. It's like, well, wouldn't that be, that's what we should do. We should say no. Wouldn't that be wonderful if it was that simple? But harm reduction, I'd love you to talk a little to that.
Yeah, I'm glad you're actually rooting it in that place for people, because I think a lot of people remember those days and those TV commercials. Remember the fried egg? This is your brain. Yeah. This is your brain on drugs. Yeah.
Brain on drugs.
So harm reduction is a response to that era of time, because those ads didn't work. That approach did not work. And all it actually did was further alienate and marginalize communities, people who use drugs, typically communities who live in poverty, and many communities of color, actually, further marginalizing them both in the United States and in Canada. Harm reduction is an approach to care which recognizes that people who use drugs can and should be able to use drugs with their own autonomy, their own will, and their own desire while receiving care and health care. But what we aim to do in the process of doing that is reducing the harms around it. We see examples of harm reduction all around us. Wearing a seatbelt in the car is harm reduction. Wearing a bike helmet is an example of harm reduction. So in healthcare, and to support people who use drugs, we are applying the same principles. Examples can include using medications like methadone for people who use opioid therapy, supervised injection sites, overdose prevention sites, or even managed alcohol programs, sites where alcohol is provided to people with severe alcohol use disorders to support them through their day. And what we know about harm reduction, and there's different types of harm reduction, is that people feel better, people tend to live longer, people tend to access healthcare a lot less, people are dealing with the police a lot less and the courts. And we've seen the evidence of this, that actually abstinence doesn't really work. Harm reduction does. Now, harm reduction in palliative care is a unique combination, because as a palliative care doctor, I can say that many of the medications that we use to treat symptoms are often the kinds of medications, the kinds of drugs that are used on the street. Okay. And so the palliative care field has not yet come to a place where they're talking about harm reduction in a robust way. We at the Peach program are, as are many kind of cousin programs across Canada, around the world. But I'm looking forward to the day when harm reduction is adopted by the palliative care community. And that's why actually most people who use drugs don't get access to palliative care in a country like Canada as a result. Until we adopt harm reduction, we won't be able to get there.
Wow, that is such an important point, right? Because we need to understand, the two need to be a part of the whole, right? We have to look at the whole picture and meet someone where they are. Again, with that respect and that dignity. And we are getting better, aren't we? Like, this is just such this has been so long. I mean, I remember all the years throughout my nursing, 30 years, and that stigma was there. And I know, with mental health being at the forefront of conversations, and I believe more and more we need to talk about homelessness. And I remember one story that I saw you shared about a gentleman who was an engineer who became homeless.
Yeah, absolutely. Yeah. I mean, it's wild to think that the fastest growing subset of people experiencing homelessness in Canada, North America, are actually people who are elderly, frail, over the age of 55. They have no knowledge of the streets or how to live on the streets. And because of this weakening social safety net that we see, they're on the streets and experiencing homelessness. And that was the story of Archie, a gentleman that I cared for, that I shared for in a radio documentary. But to your point, I just want to, say that I think, yes, things are getting better. And actually, I want to come from a strengths-focused approach and a resilience-focused approach. The communities we serve have been dealing with palliative care well before I was even born. Let's be real. There's strength there. There is resilience. There is charisma. There is courage. And the people I cared for, they are my heroes, because I wouldn't last 2 seconds dealing with what they're dealing with. And it's that kind of I think humility we need to take into this work. It's not that we're the Peach program is going into a shelter community or a housing community and saying, this is what you need to do. We're actually learning from caseworkers, from our clients, about how they manage palliative care. And it's kind of this two-way exchange of information. I think once we see it that way, we have more success. We've learned that in programs that have developed across Canada and Victoria, Edmonton, Calgary, and other cities across North America that are modeled after the Peach program or cousin programs, that actually this is a really common theme, that cultural humility that needs to take place, and that recognition of strength and resilience in the communities we serve. This is not charity work. We are not helping the weak. These people are strong and they are inspiring us.
That is just such an important point, because in any, we sometimes, I believe, we come in as like, we're here to save the day, and we're here to learn together, to offer what supports we can, and to be informed by their lived experience. People who are homeless and are thriving and surviving talk about resilience. Like, that is incredible. And there's just so much to be learned from every person. I mean, I've interviewed hundreds of people. I always say, and I'm also a do-gooder, and I say, I'm a do-gooder not because I'm a nice person, because I feel so good. And I know that I am learning from every single person I meet. I'm not going in as the expert. I'm going in with what I can offer. And we have much to learn from each other, right? From each other. Oh, this is just and I love hearing that you have sister organizations across North America. This is growing.
It is. I think people in different regions, towns, and cities and municipalities across Canada are recognizing that the palliative care inequity gap is not unique to Toronto. We see this in every city and area across Canada, and we've seen models develop. Colleagues, have developed programs in Victoria, Edmonton, Calgary, and many other cities across Canada where these mobile models are making a difference. And what we're starting to realize is that this works. It's not solving all the problems that people deal with, but it's certainly providing access to palliative care in a way that wasn't being accessed before. And so there's some truth to this. There's some power to this, and it's now something that's also being developed and being built upon in cities across the world. And we're grateful to be part of a national and international community that is deriving work around research and building practice, so that this isn't just an isolated program in my little corner of Toronto or my little corner of the world. It's something that's changing the way we view palliative care delivery everywhere.
You have created a wave of change.
You give me a lot of credit, Yvonne, but I work with an incredible team.
I'm giving you the credit. It is extraordinary. But that's the power of one person and one story. And, you are being the evidence that someone's life made a difference. You are being the evidence that Terry's life made a difference, and everyone's life who died, not in the ideal way, how they wished. We can learn from that, and we can be better. We can do better moving forward. And so with that, I'd love to know, when people say, okay, they hear about this, and what can I do? I'm not a healthcare professional. What can we as every community member, because, I believe that it is each and every one of our responsibility to shine our light in any way we can, to help in any way we can. What would be your greatest ask of every community member?
I think this is a really key question, and I know people want to turn to a place of action, particularly after conversations like this, and I love that. That's the energy we need. But I would suggest that people actually just take a step before that step and actually just take a step back, actually. And I would suggest that people listen first. That be your first step. Learn more about pathways to homelessness, learn more about the organizations that are doing incredible work in your communities. Scan the media. There are headlines around homelessness every single day in all forms of media. What is being said, what's being talked about, what's not being talked about. Learn about statistics, learn about government policies. And once you come to terms with what's happening, and by the way, some websites that can really help with that include homelesshub.ca, the Canadian Alliance to End Homelessness, Health Providers Against Poverty, the Toronto Drop-In Network, and many others. I would say that inherently, I would ask that everybody who is interested in this topic work towards ending homelessness. We have to go to a place where this issue in society is not one that we continue to accept anymore. It is a human-made problem that was created by humans and can be ended by humans. In fact, there has been more discourse than ever before during COVID-19 about what a post-COVID recovery world looks like. And we've shown in our response to supporting people experiencing homelessness during this pandemic, which there's been a lot of bright spots, a lot of positive things to talk about, that maybe we can cure and end homelessness in this country. That is inherently a political issue. People have to get political. We have to, write. We have to advocate. We need to socialize ideas. We need to destigmatize homelessness. We need to develop cost-effective arguments, effectiveness arguments, and we need to talk to our politicians. And so I think it's listen. I think and learn more about what's going on in your local community, and then inherently do the things you need to do to get political to end homelessness in Canada for good.
Oh my goodness. I love this so much, Naheed. And that is, yes, let's end homelessness. And with every little candle we light, with every, if you're going to donate $1 or $5, if you're going to have these conversations, everything makes a difference. Every small step in the right direction makes a difference. And I would also encourage people to learn more about Dr. Naheed Dosani. Watch his TikToks. They totally rock. And Naheed, I just have to say thank you from the bottom of my heart and soul for all that you do. It is absolutely extraordinary, and we want to support you in any way we can. So thank you so much for just showing up today and for all that you do.
Thank you so much, Yvonne. I really appreciate it. To you, your team, and the entire, community of viewers that are out there. I'm in your corner too, and really appreciate the time. Thanks so much.
Thank you so much. So thanks, everyone. This has been Real Life Talks, learning about how to just show up for ourselves and each other, and sometimes having difficult but needed conversations. So my call to action, as always, plan your life, plan your death, and then just love your life to death. And always bring your own tambourine to the party. Bye for now.
This program is brought to you by Ignite TV. Now you're in command. Visit Rogers.com for more details.
Call the Rogers TV viewer response line. Email us or connect with us on social media. This is Rogers TV, Aurelia.
Hey, Did you know?
More than 4,500 Canadians are waiting for an organ transplant right now.
Right now. 4,500.
People are dying.